Okay, great. Well, I'm going to go ahead and get started, and if anybody joins us, they'll pop into the room and catch up. So I wanted, again, welcome to our digital course. We have some great speakers on tonight, so I'm really, really excited about it. Our CEO and President, Leslie Stevens, is actually on with us, and I'd like to take just a minute, if it's okay, to tell you just a little bit about Leslie. So Leslie, of course, as I said, is our CEO. She's a mother of three. Her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. Unfortunately, there is a silent epidemic that's affecting 9 out of 10 children. This epidemic manifests itself in a variety of symptoms that can easily be overlooked, misdiagnosed, and most unfortunately left untreated. It's critical that children are evaluated for sleep and breathing habits. And so Leslie is not only our fearless leader, she lectures and trains all over the world. So I don't think there's a question in reference to the subject of pediatric sleep, breathing, airway, and HealthyStart's connection that she cannot answer. And the great thing is that she has the backing of a company like HealthyStart by Orthertain. She has 51 years behind her, 4 million cases, and tons of research. Leslie's mission is to educate both parents and oral physicians to ensure children a lifetime of health, happiness, and success. So we also have Dr. Amanda with us. Very excited to have Dr. Amanda with us as well. A lot of you guys have met her at events and have met her in different ways. So I know we're really excited to hear from her as well. So I'm going to tell you a little bit about Dr. Amanda. She is a native of San Francisco. She obtained her dental education from UCSF Dental School and her Master's of Dental Science and Orthodontic certification at the University of Connecticut Health Science Center. She practiced clinically for 10 years in the San Francisco Bay Area. And during that time, she completed thousands of orthodontic cases. Following her calling to teach and mentor, she eventually transitioned into corporate dentistry, and she's actually dedicated the last 3 years as dental director, consultant, and speaker to both national and international dental and orthodontic companies. Children and early intervention have always been her passion, and in recognizing the void in the dental industry in the field of orthodontics and early intervention, Dr. Amanda actually trained to become a clinical instructor for HealthyStart. She now dedicates her time to educating doctors in the dental connection between sleep, breathing, and airway, and how early screening and treatment can actually eliminate the future necessity of costly, painful, and a time-consuming process for these kids. Currently, Dr. Amanda resides with her family in Honolulu, Hawaii. She travels both nationally and internationally. She was actually just in Bulgaria not long ago to speak about the advantages of early orthodontic intervention. She enjoys surfing and hiking. She is I always get this wrong. She is a Girl Scout leader. I think she'll correct me. And she is actually a USA swimming official. She's bilingual in German. So before I hand the mic over to Leslie, though, I just want to tell you to please stay with us. Stay till the end. We'll actually, at the very end, we're going to tell you a little bit about our digital education platform and also how you can get your CE credits once the lecture is done. So Leslie, I'm going to hand it over to you, and please take it away.
Okay. Well, it's wonderful to be here tonight, and I am looking forward to hopefully enlightening you in some areas of sleep and breathing, especially in the pediatric practice. We see so many children out there that are affected, and unfortunately, it is kind of a silent epidemic. We notice many outward symptoms of these children, and we are fortunate that these outward symptoms basically are events or characteristics that parents can identify. So sometimes just looking at it and kind of understanding each one and how they relate to each other is very important. So if we look at these, we can look at different outward symptoms such as ADD, ADHD, bedwetting, difficulty in school, especially in the areas of math, science, or spelling, mouth breathing, snoring. Snoring's interesting. We always say, it's not like the grandfather that's taking the shutters off the house. It's more of a heavy breathing. Can you hear your child breathe? Restless sleep, delayed or stunted growth, nightmares, irritability, anger, morning headaches, chronic allergies, especially eczema and asthma, depression, tooth grinding, swollen adenoids and tonsils, aggressive behavior, daytime drowsiness, pair problems. Typically, many children who have sleep issues have few friends. Frequently wakes up at night, sleep talks, sleepwalks. But most importantly, these outward symptoms represent probably 9 out of 10 children having one or more of these symptoms present. So currently, what do we do with some of these symptoms? Many times we look at these outward symptoms and we treat them individually. We don't look at them as a whole, as possibly an explanation of maybe an underlying root cause that can be creating these outward symptoms. So parents, pediatricians, various other social workers prescribe different things for a lot of these symptoms. So we see many times drugs that are used to combat this. I will say sometimes when we see a child who is on medication, many times we see they are on maybe 3 or 4 medications. You'll see a child that has asthma, a child that has um, allergies, maybe ADD and ADHD, and they go to 3 specialists and they have various medications for each one. So it's becoming more of an epidemic, and we see more and more drugs being used with these children, and even at a very early age. We also see psychiatric testing, we see counseling, therapy, surgery, sleep studies, allergy testing, special education, sleep aids, diet changes, rapid palatal expanders are also used. But all of these items are all rather band-aids rather than treatments or cures for these outward symptoms. So we often say that they address only the symptoms and not the root cause. Many of these become short-term band-aids, and they also involve several drugs with many side effects. They can be costly, painful, time-consuming, and unfortunately ineffective. So the research over the last 20 years had linked these symptoms to a root cause. And these root causes are basically mouth breathing, a narrow palate, improper tongue placement, and jaw relations. Dental professionals have the knowledge and the tools to impact the development of a child's airway, to increase the oxygen intake and reduce carbon dioxide buildup. So as a dentist, as an orthodontist, as a pediatric dentist, it's far more about it's about far more than cavities and straight teeth. It's basically the overall future health and well-being of every child. Many times we say, don't focus in on the mouth. Let's take a step back and look at the entire child, because that's what we should be focusing on the total health rather than just the dentition. So tonight, hopefully, we'll go over and learn how to identify sleep disorder breathing symptoms, evaluate these symptoms, understand and identify the root cause, diagnose the problem, and most importantly, treat. So as you see a child that walks in, you can see them in your daily life, you can see them in your office, but start noticing different facial characteristics. I always say before a child even makes it into your dental chair, you should already have a very good idea of what's going on with that child. Here are some examples. Obviously, you can see venous pooling under the eyes. You can see an open mouth, typically mouth breathing. You will see a head that's lurched forward. Usually it's an indication that they are struggling to breathe. They need more airway, more breath, more oxygen. You can look at the profile of a child and tell a lot as well. Looking at this girl on the left, you can take a look at the profile. You can see how deficient she is in the lower third of her face. Look at the lips are parted. She's a mouth breather. Look at this child, same thing. We call this kind of a funnel look because the chin and the neck blend into each other. You can see a rolled lip. We'll talk about that later, but you can almost know exactly what's going on in the dentition. You can see the circles under the eyes. So these are all things that you should be paying attention to as a child, as you're just watching them enter into your office. So again, when we talk about the root causes, we're talking about mouth breathing. allowing the mandible and the tongue to displace posteriorly, causing a reduced airway and air exchange to lungs. Habits like finger sucking and abnormal tongue posture and swallow. Upper arch constriction and high palate, decreasing nasal breathing. And all of these reduce the REM sleep, affecting brain function, endocrine, and immune system. So when we look at a child, we look at the craniofacial growth. As we all know, craniofacial growth tends to cease at about age 12. You can see just with some of these, this data, you can see even at 2 years of age, in a male, we have 68% completion and 73% in females. So you can understand why we are so concerned with treating as soon as you see these symptoms. Looking at these kids and making such an impact so that we can promote growth and development, and we can gain the most development that we can possibly gain during that period of growth. So as you look at this drawing, you can see where the movement or where the direction of growth occurs. It's in a forward and down position. So as we are treating these kids, we're promoting the same growth that we should be seeing in these children. We already know 93% of the population of this population generation will have malocclusions. So we already know there are a lot of factors that are going to impact the growth. And obviously tonight's discussion is how sleep and breathing and those outward symptoms are prevalent characteristics that we can look at and address. And then looking at the root causes, which basically one factor is that lack of growth that we see in these kids. The growth that we are expecting to see, as we said, the development of the face and the jaw should be in a forward and down position or direction. So the question bodes, why are so many children not experiencing normal growth as well as social and personality development? Well, it's been really easy to identify through industrialization. We have seen obviously an increase in malocclusions. We see an increase in sleep and breathing issues. We see an increase in a lot of deficiency. And a lot of that relates back to looking at a pacifier. We look at nipple bottles, a lack of breastfeeding, soft diet. All of those impact the formation of the oral cavity. So if a child is sucking on a pacifier, it creates suction in the mouth. And that suction will restrict the airway and basically eliminate the room for the tongue to be positioned up in the palate. Well, if the tongue isn't up in the palate, then it's laying low. If it's laying low, obviously you have a tendency to mouth breathe. So you can kind of see where it becomes a vicious circle. When we look at a child that has had extended pacifier or nipple bottle use, we usually see an open bite. Tongue thrust, you can see these kind of dentitions as a child smiles, or even as if they're a mouth breather, and typically they are, especially in these cases, you will see this kind of configuration of the mouth. So already you know what you're going to start looking for. Important to understand the airway, nasal cavity, hard palate, where the tongue is, where the tongue placement is, soft palate. These are things maybe it's also interesting to explain to a parent, because, you know, typically when you talk about the oral cavity, they're going to think about teeth. Well, there's so much more that goes into it than just teeth. Another important feature, which often gets basically put to the side, is the function of the nose. We look at mouth breathing and we understand the harm that it does as a child is breathing and breathing through their mouth rather than the nose. But what is the function of the nose? Well, the nose has basically 5 functions. It serves as an air passageway. It warms and moistens inhaled air. The membrane traps dust, pollen, bacteria, and other foreign matters. It contains receptors which sort out odors. It aids in phonation and quality of voice. I just read a very interesting study, and it was from so many years ago, 1960, but it was done on monkeys, excuse me. And it obviously very cruel to animals, but the research that they gained is interesting. They actually put silicone cones into the monkey's nostrils, and they wanted to see what kind of facial changes would occur causing mouth breathing. And what was interesting is the face became very elongated. The features of the monkey were hard to distinguish, and they had crooked teeth. So I am hoping to include that study and show you some of those images, because that is really a powerful message, and to see how severe those changes can be in the facial structure. So when we look at improper air exchange, how many times have we seen this situation with a child in a car seat? We see that the most common problem of improper air exchange to and from the lungs is the constriction, probably due to nighttime mouth breathing. And we find it present in about 43%. And that was a recent study that was done on a sample of actually 501 patients. So I'm going to, hopefully this will start. This is Eli. This is a very interesting video to watch. Sometimes we play it for parents, because seeing this display of mouth breathing, but then seeing what was done and how we can effectively change this and actually provide a better sleep, a better rest, a better breathing for this child. So I'm going to start this, whoops, right now.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now watch what happens when I take his jaw and I just bring it forward. If I can, let's see if I can. And I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. And I brought his airway. I'm opening his airway. Just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by hear how quietly he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
So interesting. I mean, look at the change just by bringing that lower jaw forward. So what if we could provide you with an appliance that would do this in a child, but allow that child to be in the right formation, put the tongue in the right position the tongue up in the palate, allow the patient to breathe through their nose, start expanding the arches, and promote the proper growth and development of both jaws. I mean, that's it. That is ideal, and kind of what the frosting on the cake is. We're going to straighten the teeth at the same time. So it is an incredibly complete system that looks at the health, the dental condition, the malocclusions, all at the same time. And majority of these children, especially if we start young, are going to wear these appliances passively at night while they sleep. So this little quote on the bottom is really important to know. We've had some questions this week from different studies that were done. I guess an orthodontist did a study and said basically the sleep issues self-correct in patients, and the research doesn't show otherwise. Well, you know, I always say people have different quotes and they say different things, but the research doesn't show that. The research actually shows that when you find an outward symptom in a child, you will not see self-correction. And in fact, in 92.6% of the time, it will not self-correct. And I'll show you in just a minute, 30% actually worsen with age. That's a really important statistic, especially with a parent, to understand now is the time. Don't wait till tomorrow. It needs to begin today. So when we talk about airway, let's look at the restricted airway on the left-hand side. This is a 5-year-old. What we would want to see is the image on the right side of a normal airway. And you can see the difference. One is a coffee stirrer, one is a garden hose. This is an interesting case that was treated, and this was done just with the first appliance, and that being a habit corrector through the HealthyStart system. And it was a CBCT scan that was done on a 9-year-old. So let me just back up and tell you, typically, what's an average airway? How do we determine that? And there have been studies that have basically dictated that we take the age of the patient starting at age 5, multiply it by 10. So if it's a 9-year-old, we would expect a 90 square millimeter airway. At age 17, we peak. For an adult, we would expect to see an airway between 150 and 170 square millimeters. Unfortunately, at age 21, our airway starts to deteriorate. So if we look at this particular case here, we see an airway of 53.6. This is a 9-year-old. We would expect to see a 90 square millimeter airway. So obviously already compromised. The HealthyStart habit corrector was implemented. The patient wore it 1 month. The second photo is with the appliance in their mouth to see what kind of changes we are getting in the airway. And this airway measured 337 square millimeters. Not only is it 6 times greater than what we initially measured, but what is astronomical is that it's over double what we would anticipate to see in an adult. So research is currently being put underway in order to look at this to see long-term duration of this airway. It's to see on average what is the amount of airway that we can gain, and maybe more importantly, to determine that the averages that we currently have are not accurate averages. Those are not averages that we should strive for because it won't last through our lifetime. So very interesting, and we'll have more to provide you, obviously, with this research going on. So now let's talk about, interesting enough, when we look at CBCT scans, when we look at CEFs, we know that 21% of the population will have a compromised airway. So how do we have 9 out of 10 kids that have outward symptoms of sleep? So what has become a huge understanding is the effect of habits, especially mouth breathing in these children. We know that at least 43% of the children will be a mouth breather. So what happens when they mouth breathe? Just opening their mouth by a half an inch will actually restrict the airway by 6 millimeters. So if you look at a 7-year-old, you'll see a 7 millimeter airway. So if they mouth breathe, you will expect it to reduce itself to about 1 millimeter. So that means is if they're mouth breathing all night long, they're reducing their airway to about 1 millimeter. What's an important factor when we sleep that requires oxygen is REM sleep. So typically we see these children are not getting the REM sleep that we would anticipate. So again, a good comparison, does your child airway look like a coffee stirrer or a garden hose? This is the circle that occurs. Obviously, we see mouth breathing, snoring is usually a result of extended bottle feeding, pacifier use, poor tongue placement, processed foods, poor oral habits. And what then occurs is we see a compromised airway. And what does a compromised airway create? It reduces airway, restricts airflow, reduces oxygen, affects brain function, creates swollen adenoids and tonsils, low tongue position, underdeveloped dental arches, overjet, open bite, crossbite. And these compromised airways then creates a sleep disorder breathing. And these outward symptoms that we see caused by sleep disorder breathing include restless sleep, the ADD, bedwetting, chronic allergies, nightmares, daytime drowsiness, aggressive behavior, difficulty in school, frequent infections. So now let's talk a little bit about Healthy Start and what we do. So Healthy Start, again, if we reiterate, we address the root causes. And I'm just going to quickly go through this. We're going to expand the dental arches. You will find that the Healthy Start alone will basically address 77% of the arch expansion you need. We will get up to 4 to 5 millimeters of expansion with these appliances, not with an additional Schwartz and things like that, just with the appliance. We will be able to establish nasal breathing, and that means we are eliminating the mouth breathing and creating the nasal breathing. We're going to train the tongue, and how we're doing that is there's actual myofunctional therapy built into every appliance. There's a ramp that actually will lift the tongue, put the tongue in the right position, start the expansion, and it will create that proper habit. So every night we swallow 1 time a minute. During the day, we swallow 2 times a minute. So just by wearing these appliances at night, we reinforce and repeat that proper swallow pattern and tongue position 500 times each and every night. We eliminate bad habits, thumb sucking, tongue thrust, reverse swallow, open bites. We also advance the mandible to correct the overjet. We also encourage the proper facial and body growth. We also correct most orthodontic problems. And that includes any overbite, any overjet. We create perfect intercuspation of the dentition, molar relationships to a class 1, all 28 teeth in proper place by age 12. Provides fiber development on straight teeth for stability. So those teeth are going to allow to grow in straight, so the relapse is minimal. We reduce and eliminate future relapse, and we reduce the chance for orthodontic treatment later. We also correct class 3s. We also have a Max A that will be able to promote forward and downward growth of both the upper and lower arches. We treat open bites, gummy smiles, cross bites. So we basically go the gamut. Here is a research project, a research study that was done. It was published. It was on 501 kids. And this is where the statistics, 9 out of 10 children have 1 or more outward symptoms. Parents were asked to fill out a sleep questionnaire. These will be available to our doctors as well as tools to initially identify sleep and breathing patterns in children. Each condition is ranked from 0 to 5, 5 being the most pronounced. We will have them initially fill this out. Then we'll also have them fill it out 3 months into treatment to evaluate. We also have an app available that they will be able to monitor on a daily basis, so we can see real-time changes in these cases. Important results and takeaways from the study: mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptom. 9 out of 10 children have 1 or more symptoms of sleep disorder breathing. 60% of the sample had 4 or more symptoms. 1 out of 5 children experienced bedwetting. Kind of an interesting fact, 9% are bedwetters at an older age. I didn't realize it was that prevalent. Between 4 and 12 years of age, 92.6% of symptoms did not self-correct, while 30% worsened with age. I can't say it enough. That's a really important aspect. The sleep deprivation, we look at the different conditions and the percentages that occurred. Obviously, you can see mouth breathing seems to always be at the top of the list. Frequent symptoms found in children who mouth breathe during the night. You can see they snore, difficulty listening, and often interrupts talks while sleeping. You can go down the list. Implications of this study. The findings show that sleep disorder breathing is much more common and affects children even as young as 2 years of age. Begin treatment as early as possible to ensure permanent changes. Identifying outward symptoms displayed in 90% of the children that enter your practice can significantly reduce this epidemic and enable you to successfully treat the overall health of your patient. So let me tell you what 9 out of 10 children represent in the United States right now. That represents 40 million children that are out there. I would say majority of them are either undiagnosed or misdiagnosed. So you as a dental professional are in an ideal position to be really the oral physician for these children, to identify this and basically educate the parents. And that's what we hope you take away from tonight, because it is really important that we talk about these symptoms and be able to educate a parent, let a parent decide what they want to do with their child. But once you explain it to them, there is just no way that a parent isn't basically desperate to get this taken care of for their child. We all want the very best for our child, and whatever we can do to basically remove the barriers that prevent them from succeeding. So I'm going to quickly go through a couple research articles and studies that really are important to understand. So here is an MRI of a normal brain function, which is basically of a person that had a normal night's sleep. This is the next morning they did an MRI. Now, with one night of sleep deprivation, the lower one shows the brain activity. Look at what you see, hardly anything. It's once you see the image, you can't forget it. You realize the impact just one night of sleep deprivation can have. So let's look at some of the other studies. Less REM sleep interferes with the removal of intracellular brain toxins. It's usually referred to as beta amyloid. And we see this typically in Alzheimer's patients. But what's interesting is we see the blood cells that expand during the day, the toxins build up. At night, when we get into REM sleep, those brain cells should shrink and those fluids should wash away. Unfortunately, when we do not get into REM sleep, those fluids and those toxins build up. And that's what we see typically in an Alzheimer and dementia patient. But this also continues even with patients that aren't portraying those symptoms, but we see the buildup of toxins. The plaque between brain cells, as we talked about before, beta amyloid, 3 consecutive nights of 4 to 5 hours of sleep can cause irreversible brain cell damage. That was from a study done at University of Pennsylvania. Antibody levels increase 56% for each additional hour of sleep. One night of incomplete sleep can affect endocrine and immune system from Harvard Medical School. Insulin, we can go down here. Children 6 to 9 years old with less than 10 hours of sleep were 1.5 to 2.5 times more likely to be obese. Increased risk of type 2 diabetes. Effect on immune systems result in less resistance to infections, illness, and allergies. So let's quickly go over ADD. There was an amazing study that was done by Bonnick on over 13,000 participants. And she found that 50% of patients with ADD and ADHD or sleep disorder breathing increases risk of ADD by at least 50%. ADD and ADHD patients have little or no REM sleep, but they have delta sleep. Patients without ADD or ADHD have primarily REM sleep and delta sleep. Interesting is that the most recent studies showed that 86% of children who had ADD and ADHD had sleep issues. A huge statistic. What are the detriments to being, when we look at these children that have ADD and ADHD, we find that 50% are held back 1 grade, 30% are held back 2 grades. Well, interesting enough, the criteria that we use to diagnose ADD and ADHD is the same criteria we diagnose sleep disorder breathing. Can they be misdiagnosed? Absolutely. What if you have a child that is labeled ADD and ADHD who have sleep issues instead? If you held them back 10 grades, it's not going to make a difference. It's still going to be the same issue. Sleep disorder breathing and bedwetting. Again, as I said, 18.7%. It is reduced oxygen probably interferes with normal sleep. And that's what we are seeing. It disrupts and unbalances the endocrine and the immune systems, which then obviously can result in bladder dysfunction. So habit correctors, I'll just briefly show you what they look like, and then I'm going to pass it over to Amanda. So currently we have 4 million cases that have been treated worldwide. Our appliances are FDA cleared. There's no latex, no plasticizers. They're BPA free, phthalate free, no silicone. All appliances are regulated to a Class 2 medical device, meaning that you could actually take these appliances and put them into your body and live fine with them inside your body. That's the safety regimen that we basically adhere to. We realize these are appliances that are put into your children. We want to make sure they're the safest appliance that we can manufacture for you. So here's a list of what the appliances look like. Depending on the age of when that child comes in, if they're a toddler, meaning that that patient is 2 to 4 years old, we will start with that very first appliance, and then they can continue into the other age. Now, if you have a child who comes in who's age 5, we'll go into the kids section, which is age 4 to 7, meaning that they will start with a habit corrector. The second appliance they use will be called the C series, and the third and final appliance will be the IG or the G. If a preteen child comes in, age 8 to 12, they will go through 2 appliances, because the CS appliance is basically designed for the mixed dentition or for the primary dentition, and because they're preteen, they don't have that. And then the teen and adult have 2 appliances as well, and the second one being the appliance that they will finish and retain their cases for. So Amanda, I don't know if you're ready, but let me pass the baton over to you, and you can get started. Amanda?
You know, Leslie, she messaged.
Oh, there we go. No. We're good. It was on mute. My bad. Hey, everyone. I'm super excited today. Love that mute. Don't jump off now because of the technical difficulties, because they're over, and I know you all are there, and I know you all are really excited now that you've learned about SDB, SRDB, SCRB, whatever you want to call it, your favorite acronym. Let's go ahead and segue into the ortho component. So this appliance system has a lot of benefits, and no matter which direction you're coming from, if you're an airway-focused dentist, you're a sleep-focused dentist, you're an orthodontic-focused dentist, you're just a dentist looking to do something else. The cool part about this system is it has something for you, and it really has something, I think, for all your patients, especially the patients in that 2 to 12 age range, and I'm sure you have patients in that age range. So, and if you don't, your adult patients have kids in that age range, so it's a great way to grow your practice. So let's go ahead, get started, and tell you more about the orthodontic benefits. So I titled my presentation, The Ultimate Phase 1 Plus Solution. Yes, that's what we believe. We believe it's a Phase 1 Plus option. That means it does more than Phase 1. And actually, it can be considered comprehensive as well. And that's a whole nother conversation. And if you're not really in the land of ortho, we can talk about it offline. But you will get really excited. Thank you for the introduction, Susie. This is me. Here's my contact information. I've had a lot of adventures with HealthyStart. I'm super excited to continue those adventures and reach out to many of you in more countries and bring HealthyStart to your lands. But anyways, what got us here today? Of course, we're focusing on the 2017 ADA referendum, which basically says, I'm going to translate it, at least in the world of children, okay? So yes, it's saying that it's now standard of care for all dentists in the US to be screening for OSA and SRDB, okay? That means you need to be screening all your kids, children and adults, all your patients need to be screened. From there, you'll need to either work with, for the adults, an MD to get a prescription when prescribed to help treat these patients or refer them out. For kids, it's a totally different world. And this is where I think sometimes people get confused because they say, well, don't you need a physician to write a prescription? No, not necessarily. Because in kids, that SRDB or these symptoms are often an underlying root cause. And the underlying root cause means this child was very unlikely just to be born with these symptoms. And this child is still growing. So what can we do to help possibly eliminate this from happening in this as an adult? What can we do? What do we see? What is the cause? As an adult, there's not much we can do. Like what Leslie was saying, we just a Band-Aid. Well, we fixed this symptom with this splint. We fixed this with that. we're going to put the CPAP on the patient, but are we fixing it? No. Ultimately, the patient maybe has a large neck circumference, or the patient has a retrographic mandible, and that's why they're snoring. Not much we can do. We can have maybe a surgery, but not much we can do. In kids, we can do an awful lot. So the vast majority of children can be treated with the HealthyStart appliance system. And it's a system, it's not just one appliance. And because we're treating the underlying root cause, and often we're eliminating this problem from occurring later. So I think it's absolutely wonderful. And I know it's changed so many lives. Now, since I'm an orthodontist, I'm going to tell you about the orthodontist who invented this product. He's really a mentor of mine. I really look up to him. And I think that really the story of this evolution is a cool story. And of course, Dr. Bergeson tells it way better than I do. So this is a translated version, and hopefully someday you get a chance to hear it from him. But if you do sign up for a digital course, you're going to hear a lot of snippets of Dr. B speaking. He's amazing. I learn something new every time I listen to him speak, and he will tell you the story probably directly. But okay, so basically Dr. B had the OG patent on the positioner, right? We've all used positioners, or maybe you had a positioner. I know my husband had a positioner, and after his braces were off, and that was back when those braces had all the bands around them and all that, you had to settle the bite, right? So they got positioners, and he started noticing his positioner patients, well, there was a lot of awesome things happening to them besides just their bite looking good, right? What else happened? These positioner patients started sleeping better, and saying that they were having better sleep and feeling better the next day and having systemic benefits. And he said, oh, that's interesting. And he started looking into it, and he realized, well, maybe it's because their mandible's sitting forward, or maybe because they're just getting better airway because they're breathing through their nose. So he said, hey, let me create another product. And this is kind of where the rest of the appliances came from. And from there were more advancements. But now it's rebranded. It does a lot more things than it did before. But you may have heard about the original Orthotane appliances. I know that's how I was first introduced to the system. Always positive things I hear about these appliances from some of these dentists that were 60, 70, 80 years old. They tell me about the stories of Dr. B being an instructor, or Orthotane being an amazing appliance system. And I really was excited to learn more about it. So about 2 years ago, I went, took the course. I was blown away. I just all of a sudden thought of all these patients I could have done differently. Oh my goodness. Why am I learning this so late? But it's never too late to learn something new. And it's never too late to teach someone something new, whether it be a patient, a pediatrician, or another dentist. So we talked about all the benefits of HealthyStart because it addresses the root causes in kids. It expands dental arches. It establishes nasal breathing. It trains the tongue. It eliminates habits, bad habits. Especially bad oral habits. It opens the airway by advancing the mandible if it's needed. It corrects malocclusion, encourages proper facial and body growth, reduces the risk of future relapse, and gets those, really this is a special one, it gets those cusp flosses into that perfect relationship. And we're going to show you some cases at the end, which is why you absolutely have to stay on to the end of the webinar. Also, because Susie, of course, has a special offer for you. So if you jump off, you're not going to get that special offer to join on our become a provider. It's going to be a really good offer. So you want to stay on only to the docs who stay on to the end. So stay on. But yeah, these cases, I mean, crazy. It's basically like they had a positioner. Well, they do have a positioner because everything is perfect. And I don't know if you know, but when we finished our board cases, setting cases up for our dental boards, for our orthodontic boards, we use positioners often. And they probably were Dr. B's positioners. And that's how we got the cases, quote, perfect. So you're basically getting these cases, quote, board perfect. I think that's pretty neat. It's pretty unlikely that you'll find an orthodontist that will criticize your cases, assuming they were compliant and went all the way through because they're perfect. So that's what I love about this. What's different? How is the HealthyStart appliance system different from, say, Invisalign, or different from, say, braces? Well, it's actually totally different, and just fundamentally it's different because these other systems, what they'll do is they'll apply an external force on an already erupted tooth, whereas the HealthyStart appliance system does it completely different. They are taking a tooth that is just starting to erupt, and they're basically kind of surrounding it in a really, really soft plasticky material so that the tooth is like a parking garage. It just goes where it's directed to go. It's not pushed. It just guides right in because it bounces off the side and it goes this way and it goes, oh, I guess I'm supposed to go here. Well, guess what? This tooth would have been crooked, but because it was guided into place, not pushed, There was no external force besides the actual natural eruption forces of the teeth themselves in their own PDLs. It thinks it's straight. So teeth that come up straight, they stay straight, yeah? Because they don't relapse. So I think that's really, really cool. You like that? I do. All right, malocclusion research. Listen, this is the most important part, and we remember in the comprehensive course is our 16-hour course to get certified. It's a lot, but it's a lot because we have so much to teach you. So we're literally flying through this today. We're giving you snippets of what we have for you. Maybe you're getting lost on some parts. Please, if you get lost, we'll flash our information up at the end. Feel free to connect with us and we can explain things more because that's really important. I want you to fundamentally understand what we have to offer. Because we know that once you know what we have to offer, you're going to realize it's an awesome opportunity for you and your practice and your patients. So malocclusion research, tons of research is out there. Basically, in a nutshell, it's going to tell you what's happening if you don't treat these patients, if you choose to wait, what things are going to get worse, what things are going to get better. I want you to be really familiar with this research because I want you to be able to look at any 2-year-old patient. You're going to have the power to look at any and every 2-year-old patient in your office and say, Alakaboo, Alexam, I predict this child will look like this. And you'll be able to say, you will have crooked teeth, 6 millimeters. You will have spacing, 2 millimeters. You will have a 6 millimeter overjet, boom. I can honestly tell you I have that power now, only because a lot of experience and I read all the articles and I pretty much know what I'm doing now. But most orthodontists can do that. But I know every single dentist on this call can also do this. So what gets worse, right? Well, crowding gets worse. We know that those 2-year-olds, you hear this all the time. These 2-year-olds come in, they have that kind of perfect little chiclet teeth, and the mom goes, oh, he smiles so cute. And you're thinking like, oh, well, it's going to get worse because he doesn't have spaces. And, you know, they come back and then they go, what happened? You know, I told you so. So, but at that time, what could we do, right? In my head, I'm like, well, I just got to wait till you get 2 to 2 in, and then we can maybe do some expanders, and then maybe we can do phase 1, but we're going to use up your insurance. And then, oh no, then you're going to wait, and we're going to put on some retainers, but they're probably not going to fit very well because you're going to outgrow them, and I'm going to have to adjust the plastic 100 times, then you're going to, and oh yeah, and all that. And then we'll start phase 2, but by the way, insurance is not going to cover the phase 2. Because we already burned out your insurance. You're going to have to pay in full. So your out-of-pocket cost is going to be $7,000. Anyways, you get the idea. And then you're going to have retainers, and then you're probably going to lose them. And okay, so I'm just telling you the basic scenario of what the average situation like this goes through. So yes, crowding gets worse, right? Overjet, a little bit worse, stay about the same, does not get better is the main thing. Overbite. Overbites always get worse. So, and I can tell you personal stories about my challenges with my overbite. I'll leave that to another call because I know you all are very tired, and that's a long, long, long story. But it's an interesting story, so I'm glad to share it later. Feel free to share it with your patients. Spacing gets better, but besides that, open bites get worse, right? Because you have an open bite, then later they have more difficult with tongue thrust and all sorts of other things happen, and the arches get more narrow, which exacerbates the negative direction of the facial growth, and the open bite gets worse, right? Okay, they get worse. So that's what happens. Basically, in a nutshell, we won't teach you everything about all the appliances because there's so much to say, but we have a lot of different appliances. You're going to get a full treatment plan. You're going to submit a case. We're going to tell you what we recommend that you do. You get to approve the treatment. It's not unlike many other systems out there, but it is unlike any other systems out there because we're seeing little kids, right? And we're doing healthy guiding treatment, not doing external forces, and we're helping airway, and we're removing habits. No one else is doing this, so this is pretty exciting. The key to success for HealthyStart, and you have to get this in your head, is that the younger you start, the more you can do. The younger you start, the harder cases you can do. The younger you start, really, the more successful you often can be. So we really, really want you screening the 2, 3, 4, 5, 6, 7. We want you screening up to 12, of course. But ideal patients are in that, you know, at least to start leave with habits is 2 to 7, okay? So these are kids that are an untapped market right now. And I'd say almost every ortho office, it's an untapped market. I don't care which ortho office you go to, anywhere, ask them, do you see kids under age 7? No, I don't see them because the AAO says I shouldn't see them till 7. Well, you can now. So now you can take this nice little untapped market. You can educate the parents about the benefits of eruptive guidance, about early habit elimination, about SDV, SRDV, airway benefits. Here's all the things we can do for you if you want to start early. And yes, by the way, there's added benefits on top of that. Your kid might feel better. Your kid might look better. Your kid might have more energy. Your kid might have less likely a need for phase 2, less likely a need for relapse. So it's all really exciting stuff. Here's some of the family of the EGA, eruptive guidance appliances. Remember, we're going to help you find out the right one to prescribe. We're going to help you size it. We're going to help guide you through what records you need to submit. So don't obsess on that too much now. Talk about growth modification. Gosh, I had a great doctor that asked me today. They're like, well, you know, I have this orthodontist who's seeing this patient and they're doing a high pole headgear and they're doing her at the same time, and braces. Who would want that all at one time? I can't imagine having a high pole headgear and a herp, the little piston thing, and braces. How torturous can that be for an 8-year-old? I can't imagine. I have a 9-year-old. She would be furious with me. And even if I did it, she would be the biggest pain and she'd be the worst patient. And I don't want to take that patient home with me. So, and you know what? Parents, sometimes they don't know. You say that's what you need to do and they think that's the only thing you need to do. But if you offer them that, and there's risks to what they're doing with that too. And I can talk about that for a mile versus this. And possibly this is going to even be less money because the lab cost is less. They're going to pick this. They definitely are. And, you know, the only pushback that you sometimes get is the compliance aspect. And we're going to go over all that because we have answers for all that. It's all worked out. 54% more mandibular growth. Yes, our appliances do grow mandibles. Yes, a lot of this appositional growth in the condyle area, that's okay because that's how jaws grow, right? But the main thing is that it is growing. And, you know, I had this one program director that kept saying, there's no way functional appliances don't work. They don't grow jaws. Well, you know what? Clearly they do because we have the research to back it up. So yeah, if you are using it at the wrong timing, if I stick our appliances in a 15-year-old, well, no, they're not growing jaws. So you have to do the right timing. And for us, the timing is that early time, you know, that 6, 7, 8-ish in there, maybe 9. No, we're not doing it at 12, ideally. You might get something. It depends on where the patient is along their skeletal growth curve. There's a lot of variables that need to take into place. But yes, on average, 54% more mandibular growth if you are compliant and you're using at the right time period. Well, that's exciting because you know what? I saw this patient earlier this week visiting a doctor friend of mine up in Texas, East Texas. I was just hanging out while he was doing his consults, and this patient comes in, little tiny patient. I'm going to digress and tell you a story, but it's going to be a good story. You have to stay on. Patient looked like he was like 4. I look at him, he's got a really retrographic jaw, and I look at the staff, and they've already been educated a little bit about airway and what things to look for. And I was so proud of them. They were like, we got to take a SAF. We got to check airway. Oh, yeah, you do. So they take the SAF, and they were blown away. They were blown away because this kid, and you saw that picture that Leslie put up earlier of the, you know, the airway being small and the garden hose versus the coffee straw. This kid didn't even have a coffee straw. This kid, I couldn't even see the airway. There was adenoids blown up everywhere. They're literally the only airway I saw, and this is his airway upright. I hate to see what his airway would look like lying down because it's going to get even smaller. It was at most the diameter of a very fine pencil tip, and that's a generous way to put it. I actually couldn't see it at all. He had no airway to me. Well, of course, this doctor is HealthyStart certified. So proud of this doctor. He went, you know what? Maybe it would be a good HealthyStart patient, but we need to send, you know, we got to send this patient to the physician first. You know, this patient is very sick. So yes, he went to the ENT. Hopefully it's a great ENT. They work with some good ones. Hopefully they're gonna correct this patient, make him healthy, happy. Had a lot of systemic issues too that I can't really talk about, but yeah, amazing case. And you know what? Once you start to educate others around you, they will get it. And the parents are blown away because this parent, I can't believe it. This parent had talked to so many specialists, and he's from a small town, but he really, really tried, and no one could give him the answers why his child had all these different symptoms, you know, and why is my child so small? Yeah, that's most likely what it was. It's probably airway. It all comes back to airway, and that's really the foundation of the HealthyStart appliance system. So yeah, we talked about timing. Timing is ideal. You have to get the timing right. Oh my goodness, we have questions. I feel so honored. Let's see what it is. Here we go. How long are your appliances worn? Is the 14-year-old retainer worn lifelong? This is an awesome question, okay? So appliances, this is my answer, and Leslie may jump in and say something slightly different, and there's different ways to do it. But my answer is you need to wear the appliances, okay, until not only you have the alignment that you need, but also until the patient is skeletally mature, okay? At that time, if it was a more challenging bite, and all this will be put into your treatment plan, so don't stress out about this, because they'll take the doctor team that helps to review and create your treatment plan, your suggested treatment plan, will work with you on this. But in general, for an average case, once they're skeletally mature, once they are dentally mature, you can go ahead and discontinue. Some parents, there's nothing wrong with using that last appliance as a retainer. No problems. You probably don't need it, but they get the benefits of the sleep disordered breathing with it too. So, I'll be honest, I can tell you so many stories. The patients don't want to stop sleeping with it because they feel good when they wake up. So great, you go ahead and wear it. But if it's a really, really deep bite, a severe overbite, it's recommended you continue wearing it at least one night a week. But hopefully that answers. But basically, we're going to show you a lot of cases and more if you actually take the actual course. These are cases where they discontinued. They had crooked teeth. They discontinued at 12. No relapse. And I can tell you, I've had braces 3 times because of lower incisor relapse. So if I can give that gift to any of my patients, to anyone, that is a major gift. So your patients will love you. Great question. And I think we might have some more hiding in here. Oh, I'm sorry. The question is, how long is our webinar? We try to keep it under an hour, but we have so much to say it might go a little over. So hang in there. All right. That's the last of those questions. Don't worry, I talk fast. Nighttime exercises. So some of you who are coming from the land of maybe some other myofunctional-esque, I'm not going to name them, appliance systems, maybe you're certified in some other systems, we are the nighttime exercising person. That means, yes, you can get your workout done while you sleep. How great is that? People have been trying to invent, systems like that forever, right? You just sleep and the pounds come off, right? Well, this isn't pounds, but just sleep and the myofunctional exercises are done. You don't even have to think about it because all the patents that Dr. Bergeson created and put into this appliance system are so amazing and strong that it does the work while you sleep. It says, hey, tongue, you can't go here. You need to swallow here because we have these little friendly reminders in here. And no, you can't go back, lower jaw. So it's all built in there. So the child is sleeping and swallowing so many times during the night. It's just exercising by itself. Now, occasionally, like I said, there's some one-off. If the case is really, really, really challenging or you started a little too late, sometimes we'll ask you to wear an appliance actively. Actively is really not that hard. That means 1, 2, 3 hours a day. That means you don't have to wear it to school. You just having the kid pop it in and give me any parent that says they can't do this because I'll find the time for them. I'm really good at that. So, okay, tell me your schedule. In the morning I get up and then I watch TV and then I brush my hair and take a shower. Okay, great. There's 40 minutes right now. You can wear it then. Tell me about what you do after school. I have a 30-minute commute back home. Okay, great. Put it in your mouth then. And then I game for 30 minutes and then I do my homework for 30 minutes and then I watch. Okay, that's all great. So you can think of, it's very easy to wear it during the day and kind of chew around on it. And it's actually kind of soothing. Compliance. I told you I was going to tell you about compliance. So the cool thing about our proprietary plastic that no one else has is it does have built-in compliance indicator. No, not like Invisalign's little dot. The whole thing is in a compliance indicator in that if the child wears it, it doesn't stay that beautiful shade of clear. It turns opaque. But that's okay because that's going to tell you the child really, really wore it, right? Child comes back, it's all crystal clear. After a month and that, you didn't really wear it. So, but you may not want to tell the parent that. You can just say, oh no, and then you'll know. We also have a compliance app in a doctor dashboard. Not similar to, but not quite similar to what is the dental monitoring system. I'm using that as a comparison because some of you might be familiar with it. I think it's a cool system, but ours has some of the functionality of that in that you can communicate with your patient, take pictures. No, it doesn't quantify anything. But it's still really great, and it's an extra bonus. So I'm going to go ahead and show you this video. that I took on my own cell phone of the app and some of the features. I'm going to talk you through it. Here we go. Hello. Go. All right, so I'm going to talk you through this. Welcome to HealthyStart Land. So this is an app that your patient, you guys can all get your phones out right now and download it. So go to HealthyStart in the Google Play, Apple Store, get it right now. It's free, download it. It's going to look like that little blue and green tooth, just in case there's something else named like that. Download it. Now, once you get it, you're not going to have all the features open, okay? You're going to have some of these options, but not all because you're not a patient. So if you want to have all the access like this, you need to be a patient. This was my daughter's on her phone. But you're going to get in as a patient, and to activate it, you become a patient. Once you submit your case into the portal, and we'll go over that in a few minutes, it will give you an opportunity to give you the parent's email. Then the parent will be sent a PIN code to go in. So that's how you activate it, right? So your parents are not going to have access until you submit that case. So just like you submit for Invisalign, you submit for ClearCorrect, same way, it works same way. You have a portal, you submit the records, right? Hit go, and then it goes, right? Okay, so we're getting around, getting information, we're going to the bookstore, going to the movie theater, we're learning things. But the other cool thing is that you can use it to record videos that doctor can upload to YouTube. You can use it to take progress pictures that the doctor can review and upload into your, later into your whatever, Open Dental, Dexis, whatever, I don't know, whatever you use. You can upload it in that. For progress pictures, that's great. And if you see something that's not happening, you can give the patient a call. You also have what's coolest is the compliance app. I call it the wooden nickel, you know, like typical wooden nickel, where basically, that's the video. That's basically like where the patient can come in and mark how much they wore it. You know, Monday, I wore it for 4 hours. Tuesday, I wore it all night long. And then you get little rewards, dollars, or I don't know, like pennies or something, virtual coins. You get them, and then you have the option to redeem your coins. You can bank them up, or you can redeem them in there's a store where you can get like stuff. Last I saw, there was t-shirts and pajamas, cool stuff that patients would actually want, or you can use them to play video games. And I have from my son, who's 12 and is a huge gamer, the thumbs up that, quote, the games are very cool. So I'm not a gamer myself, so I really can't vet that, but I think that's really cool. And I think all the patients will be really excited about that. All right, let's move on. So let's talk a little bit about the ROI of the system. What differentiates this system from perhaps other orthodontic systems that are comparable out there? I mean, obviously we talked about the benefits and how things move is totally different, right? We talked about the airway, and that's totally different. But what about chair time? You know, what's the catch? I always say, what's the catch? Well, I have a hard time telling you the catch because obviously I'm telling you all the benefits and I really can't think of anything that's really, I don't know. But another benefit I'm going to tell you, chair time. Listen, if you're sitting with this patient every month and doing all this and tightening wires, you got an ROI to your doctor chair time. You should know your value of your doctor time. You have an ROI to your staff. You should know the value of their time. You're paying them to do stuff. So if they're not doing stuff, they can do more stuff, right? You know, and you're already getting paid for this anyways. So it's going to do its job. You really don't have to do very much hands-on stuff. The biggest doctor component really is the diagnostic section. And of course, your staff can take all those records, right? You're just going to review them, talk to the patient, a couple, you know, measurements that maybe isn't stuff you've normally done, but we're going to teach you exactly what's needed. You're going to upload it. You're going to send it in. A couple weeks later, you're going to get the recommended treatment plan once everything is reviewed and goes kind of through our computer and goes through our doctors. We really take a good amount of time to really vet these cases, to really come up with a solid treatment plan. These are kids, so we want things to be right. We're not just straightening teeth, pushing them forward, flaring incisors, expanding arches. No, we're fixing bites. We're fixing health. We're fixing airway. There's a lot of things that go into getting these cases right. So let's talk about that. Let's talk about fees. We talked about fees, right? You need to make money on this, of course, right? I mean, you can't be paying like $2,000 for a case because then how expensive are you going to have to charge the patient? That's not our goal. I mean, personally, this is just me speaking out loud. This is not me as a HealthyStart clinical instructor. So Leslie may strike me down, but I'm telling you, I think the price is too low, but that's okay. I mean, that's her choice. And I really think that's a fundamental core value of Dr. B. I'm not speaking for him. That's just how I think he is, that he chooses even though he knows his system is worth probably a lot more, chooses to keep that price well under what it probably should be, because he wants his appliance to be not an elitist boutique product, but to be available for the average American, the average Bulgarian, that's where I was, the average kid from Thailand. Because he wants more kids to be able to feel better, look better, and have the benefits of it. And I think that's really respectful, and that's why I like working with him. So pretty cool stuff. And Leslie did say that we've done 4 million cases to date. I mean, 4 million is an incredible amount. I think that's really, really cool. And I think we're in something like 43 countries now, and there are entire countries, just to digress, where that is their go-to orthodontic product. Let's braces, we do this. So that's how the kids are getting their teeth straightened, and it works. So lab fee is pretty low. The lab fee is going to range based on the complexity of the case. Obviously, if you're starting a case way earlier, to 5-year-old, you want to stay with the case all the way till they're 12. What do you want to do with it? How long are you going to be with the case? So the longer you're going to be with the case, the more appliances you're going to need, right? Or if it's a really complex case and maybe it's a class 3 case with a shift, well, then maybe you're going to need an extra appliance to correct that. So, but in any case, if it's a 2-year-old, and you're just correcting habits, well, then it's not that expensive. So you kind of get the idea. You get kind of what you pay for based on the complexity of the case. We talked about retention really not necessarily being needed to be used. We talked about treatment setups being done, recommended treatment setups. And the cool part is I can't say that there's any other company out like this. There may be, and if they are, hey, notify me so I can update my presentation. But as far as I know, this is the only, I call it an orthodontic company. Leslie calls it a sleep disorder breathing company and orthodontic company. But yeah, I mean, it does it all, right? But we are the only that I know of that has the initial treatment plans, not done by a technician, but done by licensed dentists and orthodontists in the U.S. So I think that's really, really cool. And you'll often get to meet some of us on the team. So really, they go through a lot of eyes. Okay, I told you I promised you cases. You guys can't jump off. You got to see my cases, or these are some cases from some of our other docs too. I'm going to talk you through some of the cool things that they're doing. It's going to be real fast. And then we're going to jump over to Susie, who's going to tell us her special stuff that she's going to tell us. So don't get discouraged yet. Great class 3 case. I love it when our doctors send in cases. We got some from all over the world now. This is a great class 3 case treated by one of our pediatric dentists in California. Fantastic job. It was a pseudo class 3. It had a shift, a functional shift, corrected fully, the bite at least, in 9 months. I mean, yes, we still have a little bit more ortho to do. We're not totally done, but the bite is corrected, and that is the hard part. And how great is this? This would have totally been a face mask case for me. An expander, 2x4 appliance, and face mask. What would I have charged? Easily $4,200 for that. So, and then that patient's not done. Now this patient needs phase 2 braces in my world. So that's another $4,000. So this parent just paid $8,000 for phase 1, phase 2. Insurance maybe carried $1,000. They have a $7,000 copay. You could do this whole thing with HealthyStart. No expanders, no face mask, right? How great is this? This patient is going to love you for this. Fantastic. And you can even close the spaces. It's not that much. It's definitely a great case for that. You could do HealthyStart from front to finish. One system, one fee instead of 2. So the parent's going to love you for that, right? Okay, let's talk about this great case. This is a case from one of our docs in Texas. This is just a little bitty kid. This is a 2-year-old, yeah? So then I told you, you can see the 2-year-old. They come in. I get these requests all the time from my friends, hey, so-and-so is still sucking our thumb. Gosh, we've tried all those tricks. We tried the positive reinforcement. We tried the stickers. I don't know if we had the hot sauce. I mean, all sorts of crazy stuff. I can tell you a million stories about what people do all over the world. It's a common problem. It's not a new problem. It's everywhere. So habits are habits. We got to get rid of them. Such an easy substitution to take that thumb out, no drama, and put the appliance in, sleep with that when they're stressed instead, or use that as a substitute. Plus, it has all the myofunctional benefits. Boom, that bite closes right down real quick. So that's exciting. I want to show you this case right here. This is kind of a case of a patient that was given an option to use a HealthyStart appliance system. Patient's mom said, it sounds a little different. I'm going to go to an orthodontist instead. So that's why I want to show you this case. Then I'll show you the difference, okay? And what happened. So, okay, we did our braces. So now, look at the You know how the gums look. We got decalcification. We have gingival inflammation. Case looks all in all pretty good. I could be a little picky on this, but not loving it. Midline's off. Edge-to-edge occlusion. I give it a, I'm not going to say who it is. So, but in any case, you know, I give it a 4. Okay, so this is kind of where it was maybe a couple of months later. Patient didn't really wear his retainers because, of course, he has to have retainers, right? And now look what's happening. Bite open up, lateral tongue thrust, right? Because they didn't control the habit. Front teeth still looking good, but bite getting all whacked out. Here's where it is a little bit later. Not so good. So, I mean, didn't turn out that great, right? Okay, so let's talk about, and I think that patient ultimately had to go get braces again. Okay, another case, case 2. Similar kind of case, similar age patient, presents a similar way. This mom said, yeah, I'll do the HealthyStart. Great, let's do it. So started, looking nice, looking really good. For me, I mean, look, it's night and day. Look at how nicely these bites are interdigitated. And I told you, I can't do it better. None of you can do it better. Look at the midline, it's fantastic. It's really perfect. Give me an orthodontist who says they can do better than this, because they won't. Whoa, look at this. 4 years later, no retention, right? I told you, no retention. Arch is still wide, bite is interdigitated, you know. How fantastic is this? So this is just, these sell the case. I mean, look at this. Look from the side. You could present this at an ABO meeting. You really, really could. And they would have a very difficult time picking this case apart. It's perfect. And I love it. So thanks for sharing your cases. All right, I'm going to show you some cases in progress. So totally not done at all. But, you know, this looks challenging. And you probably see these a lot in these 6, 7-year-olds. Oh, no, you know, this tooth's coming down at an angle. We don't have enough space. Super deep bite, right? And this, what can we do? Well, the orthodontist says we need to wait until 2x2 is in, so we can do a 2x4. We need to wait. Well, what if the parent wants to do something now? I don't want to like this. Can we do something now, please? Well, sure we can. So they went ahead, they started the HealthyStart process, which usually means starting with a habit corrector and then moving on to, probably in this case, a C appliance and then a G appliance. Don't worry about the alphabet soup. We'll go over that later, but you can start to see things are straightening up. Definitely the bite is improving. And slowly, as these teeth are up, they're going to get straightened. That's only 3 months right there. Look at this case. Started maybe a little later than we like to. We ideally want our cases, like I said, ideal case is a case with 1 wiggly tooth, right? Or 1 tooth just poking through the gums. That's the perfect case. But, you know, you're going to have a hard time finding those. So, you know, you're saying, wow, 6 millimeters of crowding right here. Mixed dentition, this case is going to be, whoa, you know, narrow arches, V-shaped arches. This patient is going to have some problems, you know, and some orthodontists will say, well, this is going to be a serial extraction case. I'm going to take out the C's and the D's, and then when the 4s come up, and take them out, and sure, you can do that, but what's going to happen to the airway? I don't know. You don't know. New articles coming out. I'm feeling really nervous about extraction cases now. Yes, I did my share of them, and now I don't think I'd do them again unless I absolutely had to. So that's just how I feel about it. So, you know what? It's an alternative. Wow, look, arches got expanded. Everything got straightened up. Amount of time, a little more than a year. That's pretty amazing. So, you know, another great case. This is just 1 month only, right? 1 month only. Wearing this appliance. He was a super wearer. He really did a great job wearing it, not just at nighttime only. They're welcome to wear it during the day if they want to. But, you know, not everyone wants to. You don't have to. But if you really want progress, you can. And take a look at, you know, it's not done, but 1 month. Amazing. There's no way you're going to get this kind of crowding resolution without taking out baby teeth. You can see the baby teeth were not taken out because so many orthodontists just go right to, and I was one too, oh, I got to pull out these C's and D's. No, we don't believe in that at all. Unless there's a major impaction, we don't believe in that. Because we believe that if the teeth are in, it helps to widen the arches naturally. That's another way you can widen the arches because it needs to push against the teeth. So we don't believe in teeth being extracted. Let them come out naturally. It will help make space. Fundamental core difference between us and our core philosophy. Another great case, this doctor is actually up in rural Alaska, so we love it. We have doctors everywhere. But this case has so many systemic issues. They're really coming from the direction, not only the SDV direction, they're also coming from the ortho direction. Obviously, the case needs braces, right? He's got anterior crossbite, but also snoring, breathing, bad breath, ear infections. This she's got trouble. You know, they're far away from everything. They're in a little town. They can't come in for all sorts of adjustments on braces. So she said, okay, let's give it a try. And she did. And look, they jumped the bite. It's such a good story. And the kids felt so much better. I think the ear infections went away. A lot of stuff went away. Because why? Well, they probably, you know, advanced the mandible. Everything's interconnected. Open the arches, which helps open up the eustachian tubes. Really, really cool stuff. And I can tell you many stories about ear infections and HealthyStart, because I know my daughter was the ear infection queen, so bad that they almost put tubes in her. Nothing, no tubes, no tubes. About that time, we had to do, she was so constricted, we had to do expander first and then the HealthyStart system. Ear infection's gone. She hasn't had a single ear infection since we started the appliance. And she was getting 4 to 5 a year before that. So magically they went away? I'm not sure. I think it was the ortho. So another great case, crowding. Just some progress cases 2 years later. Nighttime only, okay? This is a great case. This is a case from Europe, from Bulgaria. We have a lot of providers out there. They give us some great cases. This is dramatic, and I love dramatic cases because it's like, wow, you know? You see these kids all the time, really buck teeth, you know? They're totally lip incompetent because they can't get those little bitty lips over the teeth. It's so sad. And you know, what happens? These parents are waiting too long. They're saying, oh, I don't want to pay for 2 phases. I'm going to wait till they're 13, you know, and maybe we'll pull some teeth out. Okay, when you pull teeth out, you're going to flatten her lip. You're going to turn her into a moon because she already has a chin. That's going to look bad, okay? So what did the awesome doctor do? Awesome doctor got her started in HealthyStart. She did not have intraoral photos because I guess they don't do that there, but we did get some cool models, so I appreciate that. But look at this overjet. It went from 10 millimeters to ideal in just 4 months. The patient was wearing it all night and 3 hours during the day actively. And remember, I told you if it's a more tenacious issue, overjet over by older patient, you will want to wear it actively during the day. That means biting around on it, you know, 20 minutes on, 20 minutes off, and it really, really does help. Here is the final result. 1 year treatment only. The whole bite has held, okay? So clearly she had mandibular growth. You can see here what a great result. If you had taken out upper bias on her, she would look so dished in. It would age her so badly. So she's clearly lip competent now, no strain. I really, really love this case. Last case, because you can't jump off. That was our deal. So I'm going to answer questions, and then Susie's going to go over the options with our digital course. But great case here from one of our docs. Maybe he's in Utah. Fantastic case. Just 100% deep bite case. I think the story of this patient is he had tons of stomach symptoms, like almost all of them on the chart, and I don't want to call out this patient, but you know, it's a happy story. The happy story is he wore his appliances, bite opened up, all of a sudden symptoms started going away. He's feeling better. He's looking better. Look, he's all done with his braces, and he only had a HealthyStart. There's no way you could have treated this case. This case. Have intrusion arches, all sorts of mouth straps in this patient. Sure, I could have done it, but you know what? Would the patient have felt better? Not sure. So great outcome. Okay, real quick. I know you have some questions, but what type of records? I always get this. What type of records are needed to submit? Don't freak out on this list because this is the comprehensive list. It's not needed for all patients, but I really want to show you it's not that much different than what you're probably already doing for your Invisalign patients if you have them. You've never done any ortho before. Then it might be a little bit different, but we'll help you. When you go to the actual course, be it the digital course or a destination course, we literally hold your hand through this whole process. So don't freak out on this. We have a sleep and speech questionnaire. It's proprietary. We give it to you. You can digitize it. You can have it online for your resources. We recommend that every single one of your 2 to 12 patients have this screening form. And now you know it's actually standard of care. So yay, you just check that off your list of things you need to do. Add it in with your paperwork, right? Neat stuff. You can get a score on that and do follow-ups every 6 months as well. Some doctor forms, information about the exam. A pano is strongly recommended. Some other forms if you need it, if they mouth breathe. Photos, that's pretty standard. We can tell you and teach you about taking intraoral and extraoral photos if you've never done it. Don't worry about it. Models or a scan. If the patient is little, like 2, 3, 4, and you're not using the tooth moving appliances yet, you're just using the habit appliances, you don't need that then. That's not a problem. So, but for the older kids. And the tooth model, the tooth mold can just be alginate. It can be alginate, easy to take on a 5-year-old. and you can tore it up later, or you can do a scan. Doesn't matter to us. Sets, for the most, we do strongly recommend them. Sometimes maybe you don't need them, but we're never going to tell you have to have that. You know, why? Why do we want a set? Well, remember what I told you before about that patient I saw earlier this week? We're in Texas, and the little kid that came in, who turns out was 9 and had a little mandible, and the staff said, "Ooh, I think we should take a staph." And I said, "Ding, ding, ding, good idea." And I took it, and there was zero airway. It looked like zero airway to me, and gigantic adenoids. So yeah, it's good to take a staph because you're going to catch things you wouldn't have caught. And, you know, of course, that patient needed to go to ENT first because, I mean, that patient is very sick. So, but, you know, working with the ENT, they may agree for us to prescribe an oral appliance to help, you know, alleviate some of the symptoms initially. We're going to work together as a team. So really exciting stuff. So that's pretty much it. It's pretty easy breezy. We're super excited to have you guys here. Here's some information if you want to learn more about the system in general. I can flash my information up later if needed, but you can easily find me. My email is awilson@thehealthystart.com. And lastly, I'm going to go ahead and pass this up to Susie, who's going to tell us about the digital course. And if there's any questions, she'll facilitate that. Thank you.
Awesome. Thank you so much, Dr. Amanda. There actually is one question in the chat. I figured I'd go ahead and address it now, being that you just finished with the presentation. And it's
Sure.
The question is, so we do not have to extract the lower primary canines if minor moderate
No,
crowding?
ma'am. My answer is no, ma'am. Absolutely, positively, unless the tooth is like super impacted. I mean, if it's horizontally impacted, it might not even be something we can fix. But if it's like really, really, really tipped, and I think Dr. Bergeson's guidelines are somewhere around the 30%, 35% of when he recommends possibly extracting a baby canine to help facilitate the uprighting of that tooth, and that's what the studies support. But in the absence of an impacted canine, no extraction.
Awesome.
And I know it's different. I used to be the canine extracting queen. So think outside the box. Yeah, everyone can change. Oh, so many questions. Holy cow. Okay. Yes, not from an impacted canine, correct. Can you please show photos of what the appliances look like? Sure. Leslie might need to share hers. Oh, I have some. Oh, I can go back to mine. Hang on. There's a lot of appliances, okay? But I'll go back. I kind of flash through them fast because I don't like to overwhelm everyone with all the different names and stuff like that. But yeah, real quick, let me go back. I think I had them in here somewhere. This is just easier. And back. So I'll show you some of the EG, so different appliances, right? And I don't want to get into this too much and have you guys get confused. But first set of appliance is usually for most everybody is going to be the habit correctors, which Leslie talked about, and they come in a couple of different sizes, okay? Unless the patient is class 3, then it's a class 3 modified habit corrector, okay? There's also another modification of the habit corrector we call the Max A appliance. Max A appliance is for that class 1 patient with crowding where you want to move the teeth or that you want to encourage the jaw growth forward. So it basically works in the same outcome, but in a totally different way as from headgear, right? Headgear, you're like, oh, I'm trying to correct a bite. Well, I'm pushing everything back. Well, we don't want to do that because we're going to affect the airway, right? Potentially. We're making the total oral volume smaller. I want to make the oral volume bigger. And you know what? Studies show, just to digress and start talking about anthropology, science, but studies show that our mouths are not as far forward as they were a generation ago. And the more industrialized our society is, our children are having mouths that aren't growing as forward and as wide as they used to. So all you're doing is encouraging the jaw to grow where it should have grown, right? Tribal societies aren't having these problems. This is a first world problem. This airway stuff, crowding, malocclusion, bite problems, open bites, small mandibles. This is really, and there's so much research to back it up, this is an industrialized society problem. We brought it on ourselves. Now let's just not throw Band-Aids on it. Let's do interceptive treatment and fix it. Okay, that was a long answer, but yes, here's some of the appliances. These are the guidance appliances, okay? Hopefully that answered your question. Ooh, so many questions. All right. So appliances for crowding, yes. those ones I just put up, those eruptive guidance, are for chronic. And depending on how many teeth are in, where they are in the tooth loss process, there's certain modifications for some of them for bite, open bites, deep bites, or especially earlier. It depends on how, if there's 6s are in, there's different than if there's 7s are in. So yeah, but we'll help you pick the right one, and we'll help you find the right size, okay? Do most patients pay out of their pocket, or does insurance cover if there's a medical necessity? From my land, because my land is the land of ortho, patients, we bill insurance, whether we're gonna bill comprehensive, we're gonna bill interceptive, kind of depends on where you wanna go with the case. If you're just doing a habit corrector, you might bill just the removal appliance therapy, couple options. Insurance does pick up dental insurance, no problem. They don't have it, then of course they're gonna be cash patients. Medical billing is an option. It's something that we're dabbling in. We have some support for that. Some states easier than others, some insurance is easier than others. We will actually integrate that question into our whole comprehensive course. A whole hour, I think, is spent on that. And we'll tell you tips, tricks for medical billing. It's a whole different process. If Leslie's there, I'm gonna pass that off to her real quick and she can tell you a little more about it.
Yes, so medical billing is something we're in the process of. There's different ways to address it. You can look at it from a dental standpoint, meaning that you're going to be looking at the patient, not addressing or looking for a label of sleep apnea or anything like that for your patient. Obviously, the other area that we can look at is if you go down the road of actually having a child do a sleep study test and having a medical professional analyze those sleep tests and then dictate treatment, being possibly an oral appliance. So as we all know, and I think it's important to note, as a dentist, you are not allowed to diagnose sleep apnea. However, as a dentist, you're allowed to treat it. So when we talk about it, we just want to make sure that what area we're going to be pursuing. And we can help you with that. And like Amanda said, we spend a lot of time during the digital course going over that material. So hopefully that answers your question.
Perfect. Thank you so much.
Everyone's got so many great questions. I think there's one more real quick. I'm thinking about keeping the mandible forward all through the night. Doesn't the jaw and muscles hurt the next morning after wearing the appliance at night? Can it be billed for Medicaid? Yeah, we answered that. Kind of like an anterior deprogrammer. I've never heard of this being a problem. I mean, they're not taking it like, 2 feet forward. They're just taking it to a healthy position and then encouraging the jaw to grow to catch up. Anything else you have to say on that, Leslie?
No, what we hear from our patients is sometimes they say, oh, my mouth feels different, or my teeth feel like they're moving. Those are probably the more common comments that we hear. Bringing the lower jaw forward, I have not heard that. Sometimes we hear, well, my mouth hurts because I clench so hard. That's a little bit different. So we kind of try to identify. We will help you in the diagnostic forms as well and tell you some of the things. We work on kids that have maybe an inch of overjet, and you would think that would really be difficult. What's more difficult is for them to not mouth breathe. We want to make sure that we're keeping them in that position all night long. So sometimes we'll tell you that they might struggle with keeping the appliance in all night, just because if they open their mouth, that appliance is going to topple out, especially if they have that overjet correction. And we'll basically give you that indication so you can help a parent understand what's going on. And we find that, some of those kids might take a little bit longer. And as we always tell them, it's not a race. Everybody gets to the finish line. And we want to make sure the body is adapting to these appliances and that we're promoting that proper growth and development. So I wouldn't say nothing in Healthy Start hurts. And as I always say, there are really only smiles in Healthy Start. And if a child is complaining about the teeth feeling different, it's because they're moving, and that's a good sign. So I would use that as kind of the gauge on how to answer those questions for parents.
Perfect. Thank you so much. I really appreciate it. And thank you, doctors, for all of your questions. I'm going to share my screen really quickly, and I'm going to take just a couple of minutes to tell you about our digital education platform. Our digital education course is probably one of the most exciting and sought after courses out there right now. With the ADA saying that every dentist should be trained on how to assess airway, and it's really up to the dentist to get that training and to get that education. Our course fits the bill. And so I want to tell you a little bit about it because we actually give you some cases to work on while you're taking the course. So it's basically, working on your cases and taking the course at the same time. It's a 6-session digital education series, and we actually have a course starting on Monday, July the 9th. So it's coming up. So as I mentioned, hands-on treatment of 2 full cases, including, and those 2 full cases is everything, so all the different series of appliances that Dr. Amanda and Leslie were talking about are included in those 2 cases. So including the diagnosis, the appliances, the animal cases, the app for all of the, for those cases all comes with those cases in that course. You receive a $3,000 voucher towards a destination course in 2018. So if you wanted to bring your staff members out to a destination course, you could do that. The digital course is great because we do like to include all of your staff members. So you basically send me the list of the staff members, of your staff members that you'd like involved. The more the better, and we can involve them in this course. Interactive study groups to go along with each presentation, and the study groups are fantastic. So every Friday, we have a live interactive study club, and that's where we talk about, for example, the insurance questions that you have. Well, we have an insurance specialist that actually comes on the study club and gives a full presentation and the tips and tricks and all that good stuff. We have an office integration specialist, a practice integration specialist that comes on that talks all about, getting HealthyStart up and going in your office. We talk about how to talk to parents, just as well as, of course, all of the things like, for example, pediatric treatment of sleep-disordered breathing, improper facial growth and development of the dentition, screenings for sleep, breathing, and airway issues, and we even talk about increasing patient flow. And so you get 18 CE credits. You earn 18 CE credits with this course, and then 16 more when you attend one of the live courses as well. And as I mentioned, this course actually complements the ADA proposed it's not proposed any longer because it's actually been passed, the policy on sleep-related breathing disorders. So we receive a ton of testimonials on this for our course. We have doctors from all over the world that join us, and that's what's great about the digital course is that you can join from anywhere, and you can do it at your leisure. So, which is fantastic as well. Everything is recorded, so even those live interactive study clubs, if you're not able to make it on, we're going to send you a recorded version so that way you will not miss anything. So as you can see, this doctor in Australia, Dr. Palsy, he says the digital course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve. Well organized, passionate, and supportive. Doctor from Canada, I would like to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I have taken. And a doctor from Colorado, I really enjoyed the course. We've identified quite a few patients that will benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he has had swallowing problems, and we have already seen great improvement in his eating. We already have 3 more patients ready to that will be starting next week, and we can't wait to see their progress. That's actually what we hear all the time. And right now, we have a course actually that's in the progress right now. We're just on session 4. And these doctors already have so many patients that are waiting to be seen, so which is fantastic. And again, we had actually ADA take our course, and they said it was ingenious. So anyway, it's a fantastic course. So now is the time. I mentioned back to school because, of course, it's back to school for all of you. But this is actually the perfect time. there are so many kids, and as Leslie was talking about earlier, I mean, 9 out of 10 kids that are facing the symptoms, 1 or more symptoms of sleep-related breathing disorder. And these kids are suffering at school. They're not doing well at school. They're facing ADD and ADHD issues, and many times misdiagnosed. There are airway issues that they're facing that are they're being screened at the pediatrician or at the ENT and are facing a very evasive journey. There's another way for them. There's behavior issues, stress issues, anxiety issues. So this is actually the perfect tool for a parent to be able to provide their child to ensure that they have a successful school year. And so now's the perfect time. Summertime, everybody's off school. Parents want their children to do well. They want them to have a successful school year. A lot of our doctors will offer a free assessment, airway assessment. And all of these things, we will train you guys on all of the marketing materials. We're going to help you with everything. We're going to help you with, giving you everything you need to create landing pages on your websites. We're going to help you get the word out, let the community know what you're doing. So now's the time. There's lots of different ways that you can get involved. One is, of course, you can call or email. 844-KID-HEALTHY, of course, is our number at the office, or you can email contact@thehealthystart.com. If you register tonight, we'll actually send you a welcome package, and we can send you those starter appliances. So we can actually send you those habit correctors, so that way you can actually start. I'm sure that there's kids that you know right now who need help, and so you can actually give them those habit correctors and get them started. And then, of course, by the time the course starts, you'll already have some information under your belt. So the course is $3,400, an investment of $3,400. That includes everything that I talked about, but we are offering a webinar promo of $200 off the course cost. I have webinar underlined because if you actually go and sign up electronically, you can visit www.openairwaydentistry.com. There's a register now button on there. Just click that register now button. It's going to take you to a registration form, and it's going to ask for a promo code. And the promo code you're going to want to put in is webinar. And that will take that $200 off for you, so that way you can get that course at that discounted price. If there's any additional information that you would like to receive in reference to the course, you can email me at Susie@HealthyStartChild.com. So I noticed that there's a couple of extra questions. I don't know if we want to, do you want me to ask those questions really quickly so we can answer them?
Yeah, it's fine. If people need to jump off, you got all the information you needed. You're going to get your C unit. So those of you who want to stay on for those last 2 questions are welcome to.
Okay, so the first question is, do all the appliances cover both maxillary and mandibular teeth?
Yes. They're not single arch appliances, if that's your question.
Right. They're double arch, basically, so they're upper and lower attached, which is how they're effective in both straightening teeth, but also addressing the functional problem. So as we said before, we can correct any overbite, any overjet, open bite, gummy smile, class 3, cross bite, and deficiency in both the upper and lower arch. So that is the way. So it looks more like a mouth guard, I guess, is this easier way to describe it.
Perfect. And then Dr. Santos, will you be able to fix a pseudo class 3 on a 3-year-old patient?
Oh, that's the best. That's the absolute best. Yes, and it goes so quickly. I mean, obviously, I think everything we do is amazing, but that will take your breath away. So with the pseudo class 3, what we do is we have them wear it. We will ask them to wear it 2 hours during the day, where they'll push on this tab. They're actually using the most powerful muscle we have in our body, the tongue, and be able to drive that upper arch in a forward direction. Treatment time takes about 2 to 4 months. It is incredibly quick. The changes are remarkable, and the kids love it. They love playing with those tabs to push them forward. So it's a really, really exciting, successful type of treatment.
And remember, there's no permanent teeth in on if you're starting that early. So there's always a chance when the permanent teeth come in that you might have to do a little bit more. So, but it's great to get an early start.
Well, and what we'll do is we'll start with the class 3. and we'll have that
Mhm.
correction, and then we'll move into the habit corrector. And what we do find, though, is once the child has made that change or that jump in the bite, that we find normal growth and development occurring. So it moves in a forward and down direction. As I might just point out, interesting, class threes, pseudo class threes, we used to see maybe 5%. It was a smaller number. Now we're up to 25, 27%. So the question is, why are we seeing so many more of these class threes? Well, my personal opinion is the body is a funny thing. We all do things to compensate for deficiencies. So what does a child do to help with their deficiencies, especially if they can't breathe or they have airway issues? Well, try. If you slide your lower jaw forward, it feels like you're getting more air. So, with the increase in numbers that we know are existing for kids that are struggling to sleep and breathe, I feel that there is some kind of correlation between those two.
Thank you so much.
Susie, there's one last question, and it's for you.
Yes, the CE credits. So CE credits will be emailed to you. So the email that you used when you registered for this webinar, that's where your email, that's where your CE credit will be emailed. If by chance you need it sent elsewhere, just give us a call or email us at contact@thehealthystart.com, and we'll make sure to accommodate you. And we can get, we typically get your CE credits. I'm sure that you'll see them by next week. You'll see your CE credit. But if you have any questions or anything, just please contact us. Again, if you'd like to contact me directly in reference to the digital education course, you can reach me at Susie@HealthyStartChild.com. So I'd like to say thank you so much for everybody who stuck with us, and we hope that you enjoyed the information, and we hope that you will be that we'll be seeing you on July the 9th for our digital education course. Dr. Amanda, thank you so much for your time and for your expertise. And Leslie, thank you so much for your time and your expertise as well. I really, really appreciate both of you being on.
Well,
good night, everyone.
Yes, enjoy, take care, identify a child tonight. Take care.
For sure. Thank you.
Bye.
Bye.
Bye-bye.